We are on live now.
A very good evening to all the dignitaries, faculty, and the attendees. Myself, Amrita Jaipuriar, along with Dr. Moashami, extend a warm and hearty welcome to the third episode of the series of the webinar organized by NCD Committee of CEPHOG. In the previous two webinars, we had discussed diabetes mellitus, and today we are going to talk about thyroid disorders. At the outset, I would love to thank Dr. Sadha Gupta ma'am and the leaders of CEPHOG who gave me the opportunity to be a part of this academic feast. To begin with, I very respectfully invite Revered Dr. Rohana Hatatua. He is the president of CEPHOG, and CEPHOG is also led by the General Secretary, Dr. Yusuf Latif Khan. Dr. Rohana Hatatua, who is the president of CEPHOG from Colombo, and he is also the Secretary General of Asia Oceania Federation of Obs and Gynae. Sir, I welcome you on this platform for your presidential address. Over to you, sir.
Thank you, Dr. Amrita, for that kind words of introduction and for giving me an opportunity to speak a few words. So I'm very happy to be here on this webinar on thyroid dysfunction. It is organized by CEPHOG NCD committee, which is chaired by Dr. Padam Raj and co-chaired by Dr. Sadhana Gupta. I know Dr. Sadhana Gupta has been behind planning and organizing this program, and I'm very thankful to the committee for conducting several webinars, as was mentioned earlier in the recent past on important topics regarding NCDs. Firstly, I am very happy and I warmly welcome our chief guest for today, Professor Savaratnam Arul Kumar. Professor Arul Kumar has been our guiding light and force to CEPHOG, and he has been participating in almost all of our webinars, giving the programs very much value. But Professor Arul Kumar does not want to disturb the programs too much. So, but the few words he speaks at the end covers for everything, and everyone is waiting to hear Professor Arul Kumar's these words of wisdom, and they are real pearls for everyone, and it gives new ideas, new thoughts, and much knowledge. Also, I'm happy to see that Dr. Alpesh Gandhi, past president of FOXI, is the guest of honor today. And Dr. Alpesh is also a very close friend of ours and has been helping CEPHOG in many academic activities during the past few years. And today we see Dr. Narendra Malhotra, our dynamic Director, International Affairs of CEPHOG. He has conducted many webinars with international organizations, and he is organizing his next webinar with the RCOG very shortly. A very exciting program we'll be able to experience. And we have our two secretaries, Professor Yusuf Latif and Professor Farhana Devan. They have been very helpful to me in carrying on these activities, and thank you for all the assistance given. I'm thankful to Professor Sameena Begum, Dr. Saiba, Professor Kohinoor Begum, for the leaders from OGSP, and Professor Girja, who is also an active member of our World Justice organizations. Professor Aziz Abbas is the newly elected president of SOG, Dr. Preeti Kumar, Dr. Ambuja. She is a chair in our research committee in SUPONS. And so it is also encouraging to see Dr. Baba, who will be, I think, participating from Afghanistan. So I commend Dr. Sadia for getting all of the to this common platform, so that we will benefit from all their participation. And I see Dr. Amrita, he has been moderating so many programs, NCD programs, webinars during the past few months. So I thank and happy to see her, and for today's chosen topic is thyroid dysfunction. It is very appropriate and it has not been discussed very much. But as we know, thyroid dysfunction is a major issue which would have effects throughout one's life from infancy up till old age, affecting growth, menstruation by the way of normal uterine bleeding, fertility, pregnancy, and later in life with non-communicable diseases, cardiovascular diseases, and so on. So we are very fortunate that in today's webinar, most of these issues will be discussed by the learned speakers today. So we are in so we all will benefit from the discussions today. Before I end, I would like to invite everyone for the Silver Jubilee Congress of Suffolk, which is being organized and will be held at the end of September, that is September 30th to October 1st and 2nd. So I hope to see everyone there so that we will be able to meet each other face to face rather than by through Zoom. So I welcome everyone to Sri Lanka for this Silver Jubilee Congress. So without taking any more time of yours, I hand back to the moderators to continue with the program. Thank you very much.
Thank you, sir. Thank you for that address and thank you for the invitation to Sri Lanka. So we would all love to be there. And unfortunately, our General Secretary, Dr. Latif Khan, could not join this webinar, but he has sent his best wishes. The webinars couldn't have been possible without the joint effort of Dr. Padmaraj Pant and Dr. Sadhana Gupta. Padmaraj Pant, sir, is the chairperson, NCT committee, and Sadhana Gupta ma'am is the co-chair. I invite Dr. Padmaraj Pant, the chairperson, NCD committee of CEFOG. He's the head of the Department of Gynae at Tribhuvan University, Maharajganj, Nepal. Over to you, sir. We would like to hear from you a few words.
Good evening, everybody. President CEFOG, Secretary General CEFOG, co-chair of NCD committee, chief guest, today's chief guest, Professor Arul Kumaran, eminent speakers, all participants. Good evening again, and I welcome you all today's this CME program organized by Non-Communicable Disease by NCD committee with report of Dr. Sadhana Gupta. She is a very dynamic academician, and without her help, it would not be possible. I welcome you all in this seminar on thyroid dysfunction. Thank you very much.
Thank you, sir. I would be failing in my duties if I don't invite the wonderful person. It's an honor knowing Dr. Sadhana Gupta ma'am, the hard work and the groundwork she puts in each and every academic work she takes. So I would like to invite Sadhana ma'am to welcome our chief guest and guest of honor, Dr. Arul Kumaran sir and Dr. Alpesh Gandhi. Over to you, Sadhana ma'am. Ma'am, we can't hear you. Unmute yourself.
Thank you very much, Amrita, for your kind and loving word. And we warmly welcome our President CEFOG, Dr. Ruhana, all the dignitaries, all the leaders of CEFOG, which we are here, Dr. Farhana, Dr. Yusuf, Dr. Narendra Modi, and all the things, all this. So it's my duty. That is our third webinar. We have covered GDM in 2 sessions, and now today we are going to discuss thyroid disorders. We are really privileged to have Dr. Arul Kumaran to be our chief guest, who has been an inspiration to generations of people with his composed and superbly dedicated work all over the globe. We welcome Dr. Subratana Arul Kumaran to be in this webinar. He is Professor Emeritus of Obs-Gynae, St. George University of London from January 2013. Professor and Head of OB-Gynae for a decade. Foundation Professor of OB-Gynae, St. George's Medical School, University of Nicosia from 2014. And Visiting Professor, Institute of Global Health Policy Innovation, Imperial College London from 2012. He has been past president of FICO, past president of British Medical Association and RCOG, and he has been appointed Knight Bachelor by Her Majesty the Queen of UK in her birthday honors list in June 2009. And above all, he is beyond all the posts and all the honors because he is a living legend for the women health and especially Safe Motherhood Initiative. We welcome Dr. Arul Kumaran and we are very, very thankful for your kind presence and request you to say a few words to all the participants who are here in this webinar.
Thank you. Thank you very much, Sadhana, for inviting me. First of all, to you and your co-chair, Padam Raj from Nepal, Dr. Hattutu, President, and all the dignitaries, Alpesh Gandhi, guest of honor, and so on. But I think it is very important that you have selected the topic of thyroid because I have thyroid problems, so I'm keen to listen. In some way, actually, thyroid is an elixir for life. You know, if you say, because every cell in the body, every tissue, every organ needs thyroid hormone at some level to function. Dr. Hattutu mentioned it starts from very early. So you're going to cover about how to screen from neonatal hypothyroidism up to the fertility group of menstrual problems, reproductive problems, then post-reproductive age group as well. So it's very apt subject. If it is less thyroid, it is like no oil in the engine, it doesn't work well. And if it works too much of oil, then it works hyperactively. So I'm very keen to listen to all the topics, and I'm sure they will benefit by this seminar. Very important topic, and I'm sure we will gain. Thank you very much, Sadhana. Thank you.
Thank you. Thank you, Dr. Arul. Before we want to have a short answer from you for a small question. Right, we have been through your all autobiography, which we have shared in India by Amit Patki, from a very humble background from Sri Lanka to Singapore to UK. What's your message that how one can be global citizen for the well-being of each and every place? So one message which we want to have from you, please.
Well, like spoken in the Bhagavad Gita, our duty to God is to do our work, and the rewards are left to Him to decide. So I think we have to use our intellect and hard work and keep working, and then the rest is left to God, whatever He gives. That's my short answer. Hard work, 95%, intellect, 2%, support. Well, I think support from others is quite important. I would put a great proportion to my staff and so on. So there's no secret, no, it's all hard work, a little bit intellect, but a lot of support from friends and staff with whom you work. Thank you.
Thank you, sir.
Thank you.
Thank you, sir.
Thank you, sir. It is again, Dr. Alpesh Gandhi, it is our real pride and pleasure to have you as a guest of honor. Dr. Alpesh Gandhi is a person, what we always say, he is leader of masses. And Gandhi name itself, it is something symbolic of it. He has been President Foxy 2020 in what we can say, a changing page for humanity. That was the COVID year. And Dr. Alpesh Gandhi took the baton of Foxy leadership in that year. Vice President Foxy 2013, he has many posts: ICOG Governing Council, Chairperson Practical Obstetrical Committee, Vice President Gestosis, past President of Ahmedabad Society, past Joint Convener Gujarat Societies, and National Coordinator for EMOG program of JOI and Foxy. And he has been the key person to make the people sensitive for critical care in obstetrics. And we always remember women who become critical during pregnancy need critical care, and we should be ready for that. So it is Dr. Alpesh Gandhi, and we warmly welcome you and request you to say a few words for this program and your vision for.
Thank you, Dr. Sadhana, for the kind words and generous introduction. Dr. Rohana, President of SAFOG, Dr. Yusuf Latif Khan, Secretary General SAFOG, Dr. Arul Kumaran sir, who is most popular in all SAFOG region countries and who is inspiration to so many of our members. Dr. Sadhana Gupta, Dr. Padam Raj Pant, co-chair of NCD Committee of SAFOG, his dear friend Narendra, chairpersons of this webinar, faculties, dear delegates, a very good evening to all of you. First of all, I would like to congratulate Dr. Rohana, Dr. Yusuf Latif Khan, all SAFOG countries for continuing good academic and other activities. Under your able leadership, SAFOG is doing a lot of activities. We all are the witness of it. I am also thankful to Dr. Padam Raj and Sadhana Gupta for inviting me and giving this opportunity. I welcome Dr. Arul Kumaran sir on 18th July at Ahmedabad for the Silver Jubilee, prestigious Silver Jubilee oration of Ahmedabad Society. Sir, we will have you physically there. Dr. Sadhana and Dr. Padam Raj, you have selected a very, very important topic. As mentioned by Dr. Rohana and Arul Kumaran sir, this topic is something like it affects all these different lifespan from neonate, reproductive, adolescent, reproductive, menopause, postmenopausal. Throughout, it can affect different lifespan of women. And there are so many different guidelines, and day by day new guidelines are coming, and still very clear now about the diagnosis and management. Everything are very clear in some of the guidelines, but still there is some confusion, and we need to update our members. And it's good that you are doing this effort. As per SDG goal, we all have to achieve NC to decrease mortality in women because of NCD, and you all are working tirelessly for this. So I would like to congratulate the NCD committee of SAFOG. I have seen Dr. Sadhana working very hard, and she is working across India in all the societies of India. And since so many years she is working. So Dr. Sadhana Gupta, we really appreciate your work, hard work, and your dedication to help women and to work for the women's safety. My best wishes to this webinar, and once again, thank you very much for inviting me and giving this opportunity. Thank you.
Thank you, Dr. Alpesh. You are like a symbol of a rise of common Foxian to the highest post. We will like to say one or two secret that how you could achieve it.
Work hard, work honestly without any expectation of any rewards, and try to reach to each and every society and member of Foxy, and try to work for overall safety of women's healthcare. So automatically you will be there. So there is no mantra for this. This simple mantra, I think it's enough.
Thank you. So
I'm always telling that I am the most fortunate president of Foxy. In this difficult time also, who could receive maximum support from all the societies and all the Foxy members. So this is the mantra.
Thank you. So what Dr. Arul Kumaran says, what Dr. Alpesh Gandhi, it is a selfless service and reaching to all. That is the mantra for today, which we have really imbibed for the day. And now with this inaugural ceremony, I request Dr. Amrita to conduct with the scientific session first part.
Thank you. Thank you, Sadhna ma'am. Thank you, Arul Kumaran sir and Dr. Alpesh Gandhi for those wonderful guiding words. You, both of you are like lighthouses for us in this turbulent world. So now we quickly move on to the first scientific session, where we have the most renowned faculty and very eloquent speakers talking about their country perspective regarding the thyroid dysfunction in women in Southeast Asia. To chair the session, we have the finest gems and superstars, most learned and experienced doctors and teachers who have made their country proud. With regards, I invite Dr. Narendra Modi from India. Professor Narendra Modi is a very decorated doctor of our nation. He is the Managing Director, Global Rainbow Healthcare, advisor to IVF unit of prestigious medical colleges, too many publications, many guest lectures and presentations to his credit. He has edited many textbooks, achieved innumerable awards. The latest one is the Lifetime Achievement Award of 2022. Our second chairperson is Dr. Sameena Chaudhary from Bangladesh. I'm fortunate to know her. She is the chairman, OGSP Hospital and IRCH, President Endometriosis Adenomyosis Society of Bangladesh. She is also the chairman, Endometriosis Committee of CEPHOC. She is an active ambassador to FIGO and has contributed chapters in many textbooks and has many publications and presentations to her credit. Our third chairperson is Dr. Shafiqa Babak from Afghanistan. She is Associate Professor Obs and Gynae, past President of AFSOG, and National Trainer of Family Planning. Our fourth chairperson is another wonderful personality from India, Dr. Girija Wagh. She is Vice President-elect for the year 2024 and Professor, Department of Obs and Gynae, Bharati Vidyapeeth Medical College, Pune. So over to the chairpersons for the conduction of further proceedings. Over to you, chairpersons. Very
good evening to all of you. It's indeed a pleasure to be here in this CEPHOG NCD committee webinar. And what more on a disease which is so common, thyroid dysfunction, hypo and hyper. So hypo is more common, especially in our country. And we see that women come, and if we do a universal screening, so many of them come positive for hypothyroidism. So today, the respected speakers, I'm sure, are going to touch on universal screening, only TSH, TSH-T4, TSH-T3, T4, antibody use, what to use, when to use, and how to treat this NCD, and do we have any prevention? So without taking any further time, I would request my co-chairman to introduce the speaker of the day and to start the sessions. Dr. Girija or Dr. Savika, or
may I request Dr. Sameena Chaudhary to introduce our first speaker? Yes.
So we have country
perspective, sir.
Hypothyroidism from Nepal, India, and Bangladesh.
Yes, first of all, I want to introduce Dr. Ashmita from Nepal. She is an obstetrician gynecologist in Grandel International Hospital and assistant professor to UTH in Maharajganj from April 28, 2020. And she had honors and awards. And she also received Young Gynecologist Award in 2021 and highest scorer in MD and MS and gold medalist. I want to congratulate her. and she had some books on it and co-author of complete review of Luxwell General Health Services. And as a professional association, she is a permanent registration of Nepal Medical Council, life member of Nepal Medical Association, and life member of Nepal Society of Obstetrician and Gynecologists, and life member Menopause Society of Nepal. And I welcome Ashmita to speak on.
Thank you so much, ma'am. Namaste, all the way from Nepal. I'm Dr. Ashmita Ghimire, currently working as an assistant professor in Tribhuvan University Teaching Hospital. I'll be presenting on country perspective from Nepal. I'll be sharing my screen. Is my screen visible, ma'am?
Yes. Yes, ma'am.
So, once again, at the outset, I'd like to thank the organizing committee for providing me this golden opportunity. Regarding the thyroid disorder in Nepalese women, correct perspective, it is the most common endocrine disorder, as we all know. And in Nepal, in WHO 2020 data, we found that due to endocrine cause, the death was 0.16%, but as for thyroid disorder, it was not quantified. And thyroid disorder since 2002 has been diagnosed as a public health problem in Nepal. Here you can see the Nepalese women with goiter. This was the era in 1965. Women in those era used to live with this big goiter in the mountain and hilly region of Nepal. Moving on to the prevalence of thyroid disorder in Nepal, as we can see in the chart, this ranges from 17 to 40%. This is the data for male and female both. But if we exclude the female only, the data is 31%. And if you see the female to male ratio, it is 4.76:1%. Regarding the pregnant female, the study done in 2021 in our country showed that the prevalence rate was 25 to 29%. And in the infertile women, it was 18.4%. And in the postmenopausal women, it was 32%. Here you can see the Nepal divided according to major natural division. The picture of no data in the Himalayan region, there has been no study done till date. Whereas in the hilly region, in the Midwest of hilly region, the prevalence of thyroid disorder in our country is 24%. And in the Tarai region, it is 31%. Why is prevalence high in Nepal? Because it is a mountainous landlocked country which is situated far from the sea, and there's high annual rainfall with soil erosion leading to low soil iodine leading to iodine deficiency. And also there is much use of non-iodized salt and intake of various goitrogens. Regarding the classification, this is classification we all know in hypothyroidism and hyperthyroidism, both are classified as subclinical and overt. I have kept here the studies in non-pregnant and pregnant women done in our country, where we can see that subclinical hypothyroidism was more prevalent in both non-pregnant and pregnant women. Screening in Nepal, unfortunately, there are no standard screening guidelines in Nepal. However, there is a consensus statement on the management of hypothyroidism, which was stated by the Diabetic and Endocrinology Society of Nepal 2018. Can international guidelines be used in Nepal? May not be completely applicable in our country because the type of resources available in our country are limited and they are disease-changing scenario. And the current medical practice needs evidence-based and standard guidelines for the standard disease management. There were efforts from the government to decrease the thyroid prevalence. We had a successful public-private partnership between the Salt Trading Corporation and aid agency, and we had an iodized salt. We named it Ionun in a Nepali version, which eradicated the visible goiter, which I showed in the era 1965. From 55%, it decreased to 0.4%. And this was one of the Nepal's public health success story. The country is now facing thyroid disorder by part of increased iodine intake because the iodine salt has reached every corner of Nepal. And because of that, now after the 2016 assessment done by the government have reduced the iodine salt from 50 parts per million to 30 parts per million. Since there are no hypothyroidism, there are no thyroid guidelines, but there is a consensus by the Diabetic and Endocrinology Society of Nepal. So I have shortly kept the summary of our country, what they have said. They have said that they have recommended for screening in general population, where annual screening of serum TSH level is done in individuals with no access to iodized salt, aging population, individuals with type 1 diabetes mellitus, with pernicious anemia, with family history of autoimmune thyroid disorders, with psychiatric disorders, and individuals treated for hypothyroidism. For the pre-conception and the pregnant women, universal screening is recommended only in cases where women are older than 30 years, BMI 30 kg per meter square, women who reside in areas of moderate to severe iodine deficiency, presence of other autoimmune disease, symptoms of hypothyroidism, family history, past history of thyroid disease, previous head and neck eradication, use of drugs such as amiodarone and lithium, presence of circulating thyroid peroxidase antibodies, history of previous miscarriage, history of developmental delay in the family. These are the recommendations for screening. And for the diagnosis, they have recommended in our country for measurement of TSH and free T4 level in general population, but for pregnancy that they have asked for total T4 measurement. And the reference values they've advised as per the laboratory value. In the absence of reference values from the laboratory, they are given 0.45 to 4.12 milli international per liter. And pregnancy, they have advised for if range is available, trimester specific range. If not, for easy methods, they have asked first, second, and third trimester value to be 2.5, 3, and 3.5 milli international unit per ml each. And the diagnosis of autoimmune disease as anti-TPO test is recommended. For the treatment, they have done a recommendation to start. This was for hypothyroidism. So levothyroxine, start from 50 mcg per day, and to check at 4 to 8 weeks. Once the value are stable, then every 6 monthly. The dose is titrated based on the level of TSH. And for subclinical hypothyroidism, they have asked not to treat all cases, only those with greater than 10 milli international unit per ml. Following cases who have 4.5 to 10 milli international unit per ml, they have asked to treat for those with cardiovascular risk factors, symptoms of hypothyroidism, symptoms with psychiatric disorder, patients with goiter, patients with dyslipidemia, preconception, children with developmental delay, pregnant women, and those whose value has come 2 consecutive times, 4.5 and 10 milli international unit per liter. And for the monitoring and follow-up, they have advised for general population for 4 to 8 weeks initially. Once they have stabilized, 6 months to be done. For the pregnant women, for the first half of the pregnancy, they have asked to measure serum TSH and total T4 level every 4 weeks, and at least once between 26 to 32 weeks. So these are the major recommendation from my country as a consensus guideline. This is not international guideline or standard guideline. It is just a consensus statement which have been given by the Diabetic and Endocrinology Society of Nepal. So with this, I end my presentation. These are my references. Thank you all for your patience.
Yes, Sameena ma'am, your comments.
Okay. Thank you very much for excellent presentation. And she had given, and we are very much happy that you have a very successful story of iodized salt use, and that makes the 55% to 0.4% from 1965 to now. So
Yes.
I think it's a very success story, and I want to congratulate you for that. And another thing, you have mentioned all the recommendations that I liked it, that who are the high risk group and what is the screening purpose and who will be screened. For that you have given a very good recommendation about first trimester, second trimester, and also third trimester. And you also mentioned about the treatment protocol. I think at the end of this total program, we need to have a common recommendation for our Southeast Asian country, so that we can follow the same principle to all of these countries. Thank you very much. Excellent presentation. Thank you again.
Thank you.
Now I request Dr. Shafika Babak to introduce our second speaker, Dr. Richa Sharma from India.
I'm not seeing Dr. Shafika. I'm not seeing it. So
Okay.
you can ask her.
Can I speak?
Yes, ma'am.
Dr.
Dr. Girija, ma'am, you go.
So that was a wonderful overview coming from Nepal, and it was such a wonderful discussion and gives an insight to us about everything. And now it's a pleasure to hear from Dr. Richa Sharma from India. She is Professor Obijan, University College of Medical Sciences and GTB in Hospital, Delhi. And she is the FOXY NTP Committee Chairperson, National Corresponding Editor of the Jogi, Joint Secretary IIG Delhi Chapter, AOGD Endoscopy Committee Chairpersons, Member of Scientific Committee of Global Congress on Hysteroscopy, and more than 75 publications in national and international journals, and has presented several papers. What is very important is in this session, I must congratulate Dr. Sadhana ji for having such a wonderful session here, because it's giving us a lot of insights and stories that, as we heard the Nepali success story, and then it also tells us that we need to have country-specific approaches, and we have to have ways in which we can try and help women so that we can control this very, very important preventable NCD like hypothyroidism. So the screen is all yours, Dr. Richa, and please make your presentation.
Thank you, Dr. Girija ma'am, for the kind introduction. First of all, I thank the CEPHOG and NCD committee and Dr. Rohan, Dr. Padam Raj, and Dr. Sadhana Gupta ma'am for giving me this honor. My regards to Dr. Arul Kumar sir and Dr. Alpesh Gandhi sir, and my regards to the chairperson of this session, Dr. Narendra Modi sir, Dr. Sameena Chaudhary, Dr. Shafika, Dr. Girija ma'am. So I will just share my screen. Is my screen visible?
Yes, we can see you. We can see the screen also.
So a very good evening to everybody. I bring greetings from University College of Medical Sciences and GTB Hospital, Delhi. So I will be covering thyroid dysfunction in Indian women. So in India, the sub-Himalayan region, especially from Kashmir to Assam, it is a well-recognized area of endemic iodine deficiency. Now, despite the coverage of National Iodine Deficiency Control Program in India, iodine deficiency is still prevalent in many parts of our country. Now, a large survey which was based on in-house data which was collected from more than 33 lakh adult pan-India. So they had reported that 32% of Indian population is suffering from various kinds of thyroid disorder. So in North India recorded the maximum cases of hypothyroidism, whereas the South and the Western zone, they reported the cases of hyperthyroidism and the variant. And more than 59% of the infertile women, they were suffering from hypothyroidism. And in abnormal uterine bleeding, the 14% of the women were hypothyroid and 1.2 were hyperthyroid. Now, the prevalence of the self-reported goiter or the thyroid disorder in the National Family Health Survey 4, that was between 2015 to 2016, was 2.2%. And now it has increased to 2.9% according to the National Family Health Survey 5, that is between 2019 to 2021. We all know pregnancy is a natural stress test for thyroid gland. And we also know there are various devastating complications for the mother and for the baby. I'm not going into the detail because I think it will be discussed in the next session. But what is more important is that the mothers who are, the neonates who are born to the mothers having the serum free thyroxine level below 10 percentile, up to 12 weeks of gestation, they have decreased neonatal behavioral assessment score at 3 weeks of age. They have significant risk of impaired psychomotor development at 10 months of age. And then iodine deficiency. It significantly increases the risk of stillbirths and abortion. And it decreases the neurologic development in the fetal state. It also impairs the cognitive development, leading to learning disabilities, and it lowers the achievement motivation in later stage of childhood. So the WHO has revised a reference of median urinary iodine for adequate iodine nutrition in pregnancy from 150 to 250 micrograms per liter, and recommended daily allowance for iodine in pregnancy from 200 to 250 micrograms per liter. Now coming to the Indian scenario of maternal hypothyroidism. Now maternal hypothyroidism is somewhere between 1.2% to 67%. And the congenital hypothyroidism is nearly 72 cases per 1 lakh live births, which makes 0.07%. And out of which at least 1 in 1,388 infants, they are diagnosed with congenital hypothyroidism. And the maternal hyperthyroidism is 1.3 to 1.6%. Whereas the global scenario says the prevalence of maternal hypothyroidism is somewhere between 1.5 to 4%. And the congenital hypothyroidism is 0.03%. Now, this was a large systemic review and a meta-analysis which was conducted in 2021, wherein they had analyzed 1076 articles which were related to maternal hypothyroidism. And although the upper cutoff limit of TSH for defining hypothyroidism in pregnancy varied in all these studies between 2.5 to 4.5, and in overt hypothyroidism, the lower cutoff limit for free T3 and T4 was also variable. So the prevalence of overall hypothyroidism in pregnant women was 11%, and the subclinical hypothyroidism was nearly 9.5%, and overt hypothyroidism was 2.74%. Now, the second trimester of the pregnancy recorded the higher prevalence of hypothyroidism, that was 25, compared to first trimester and third trimester. And the coastal state also documented lower prevalence of hypothyroidism in comparison to non-coastal state, that was 8 versus 13. Now, if we see the distribution of maternal hypothyroidism state-wise prevalence, now we can see the map of India. Now the states which are colored with red, they have the very high prevalence, that is more than 30%. That is Jammu Kashmir, Uttarakhand, then Assam, West Bengal and Odisha. So the prevalence is very high. And then we can see the blue areas. Now these areas, they have a prevalence of maternal hypothyroidism somewhere between 20 to 29%. And those are the states of Gujarat, and then it is a Mizoram and it is a Telangana. And the green colored areas in the Indian map, you can see the prevalence is somewhere between 10 to 19%. So the green areas, these are the Andhra, then it is a Mizoram, and then UP and Madhya Pradesh. And then the rest yellow areas, we can see the prevalence is quite low. It is 0 to 9%. And these are the Maharashtra. And then here we have a Punjab, Haryana, and then Karnataka, Kerala and Tamil Nadu. So this was about the prevalence of the maternal hypothyroidism in our country, according to the recent meta-analysis which was conducted. Now coming to whether in India we have a universal screening for maternal hypothyroidism or we have a selective maternal screening. So Government of India guidelines, although the guidelines are from 2014, it is not yet revised. So according to our guidelines, the screening for hypothyroidism is recommended in the high-risk mothers. That means the high-risk factors for hypothyroidism according to the guideline is the people who are residing in the area of known moderate to severe iodine deficiency states, or they are obese, or having a history of prior thyroid dysfunction or a prior thyroid surgery, or they have a symptoms of thyroid dysfunction or the presence of goiter, or if they have a history of diagnosed mental retardation in the family or previous births, or they have any autoimmune disease like diabetes or SLE. Then if they have a past history of recurrent miscarriages, preterm delivery, intrauterine demise, preeclampsia, eclampsia, or abruption, or if they have a history of infertility, and also the use of the drugs like amiodarone, lithium, or the recent administration of iodinated radiologic contrast. But according to our FOXY guideline, GCPR 2019 and FOXY updates 2021, seeing the devastating effects of hypothyroidism, maternal hypothyroidism in the mother and the baby, so we recommend all pregnant women should be screened at first antenatal visit by measuring the serum TSH levels. Now, the trimester-specific reference range according to our national guidelines and according to the FOXY is the first trimester, the lower reference is 0.1 to 2.5 milli-international units per liter. Second trimester is between 0.2 to 3, and third trimester is 0.3 to 3. So the diagnostic criteria for the subclinical hypothyroidism is if the serum TSH is 2.5 to 10 with normal free T4 concentration. And overt if the serum TSH is more than 2.5 or 3 with low free T4 levels, or if the TSH more than 10 milli-international units per liter, irrespective of the free T4. Now, the national guidelines 2014, they have given a clear-cut flow chart as to how to manage the maternal hypothyroidism. So that is if the levels, serum TSH level is normal. That means in the first trimester, it is less than 2.5, or second or third, it is less than 3. No treatment is required. If the level of TSH is between 2.5 to 10, or it is between 3 to 10 in second and third trimester, then we have to give 25 micrograms of L-thyroxine per day during pregnancy, and then no treatment is required in postpartum period. If the maternal TSH is more than 10, in any trimester, we have to give her 50 micrograms of L-thyroxine per day, and then same dose has to be continued in postpartum phase. Now, pregnant women on treatment for hypothyroidism before pregnancy, then we have to modify the dose. And the pre-pregnancy dose of thyroxine has to be continued in postpartum phase. Now, once we start the thyroxine, then we have to repeat the TSH every 4 to 6 weeks. And the dose has to be adjusted according to the TSH. So they have given a clear guideline also how much dose we have to increase. That means in the first trimester, if the TSH is more than 2.5 and patient is on 25 micrograms, so we have to increase the dose by 25 micrograms. And then in her subsequent test also, we have to increase by 25 micrograms depending upon the level, which means that the target TSH level has to be less than equal to 2.5. And in the second trimester, if it is more than 3 TSH, then again, we have to titrate the dose depending upon if she is on currently, she is taking 50 micrograms, then we have to increase to 75. So at any cost, we have to see that the TSH does not go beyond 0.1. So if it goes below 0.1, then we have to decrease the dose in the same manner. That is, we have to decrease by 25. Suppose patient is taking 50, then we have to change to 25 and then so on. Now coming to the congenital hypothyroidism screening. Now again, there is no universal screening for this in our country, but the recommendations of Indian Society for Pediatric and Adolescent Endocrinology, they have recommended a universal screening for every newborn using a cord blood or in a postnatal blood at 48 to 72 hours of age. And if it is missed, we have to do the screening if the baby is a preterm or a low birth weight infant, or if the baby is a sick, then at least they have to be screened by the day 7. So this is about the Indian perspective, and let us join our hands and let us create the awareness regarding the hypothyroidism, because we know the devastating effects of hypothyroidism, and May 25th is a World Thyroid Day. Thank you so much for your patient hearing.
Thank you, Dr. Richa, for a very wonderful overview of everything that is happening in our country and where we stand. And as all have been talking of, Dr. Malhotra also said that we need to look at universal screening, and I wish and pray that this becomes accessible to every woman in this country. And it was nice to get the updates and very crisp guidelines from you, which we all are following in our practice. Thank you so much. So I think we can move on to our plan. And you are our very, we are very proud of you, Richa, the proud representative of India. And you spoke very well. Thank you.
Thank you so much, ma'am.
Thank you, Dr. Richa. Thank you, Dr. Girija. And now our third speaker is from Bangladesh, Dr. Saiba Akhtar. And I would request, as we can't find Dr. Shafika Babak, may I request Malhotra sir to introduce the speaker? Malhotra sir, are you there?
If he's not there, I can do it, Dr.
Yes, ma'am. You can introduce her, and Sameena ma'am can conclude the session.
Yeah.
Yeah.
So it's indeed a pleasure to introduce Professor Saiba Akhtar from Bangladesh. And she is a member of the FIGO Fistula Expert Advisory Group, President-elect International Society of Obstetric Fistula Surgeon, Chair of the South Asian Group of Fistula and Other Morbidities, and President of OB/GYN Society of Bangladesh, 2008 to 2010. She has dedicated her lifetime to eliminate obstetric fistula from the Asia and globe, and her innovations have been condom, uterine balloon, tamponade, named as Saiba's method for control of massive PTH in resource-poor settings. And she has been the winner of the awards such as Young Gynecologist Award, Fellows Honoris Causa, RCOG, Best Gynecologist Award, Best Presenter, Sher-e Bangla Award, Lifetime Achievement Award by the OGSB. And it's indeed going to be a pleasure to listen to such a senior doyen in this field of OB/GYN. And Madam will be giving us an insight on the country perspective from Bangladesh. And I'm sure her huge years of contribution to the fraternity of OB/GYN are going to be the part of this presentation. And we are eagerly waiting, Madam, to hear from you. The screen is yours.
Thank you. Am I audible?
Oh, Madam, you are audible,
Yes,
and you're
ma'am.
only we can make it in the slideshow if you don't mind.
Yes.
If we can have the slideshow on the screen, then we'll be able to see.
Yes,
Thank you
yes.
so much, Madam. Thanks.
Thank you, Sapo. Thank you, Madam Chairpersons, and thank you, everyone. It is a great pleasure for me to join here, and in the presence of the living legend like Professor Arul Kumaran, Rohana Hatato, Narendra Malhotra, our dear Sadhana Gupta, Madam, and you, all of you. Thank you so much. Sorry. So I am not going in details about the diagnosis and even management of the thyroid disorders. I am just like to focus on the Bangladesh perspective, because the subsequent speakers will speak in details about it. I am working in MUMS Institute of Fistula and Women's Health. This is a non-profit venture which deals with women's morbidities, especially urogynecological problems. It provides treatment absolutely at free of cost, provides training to doctors and nurses. We work for ultra-poor women, and we care for women's quality of life and provides rehabilitation in small scale. Yeah. Yes. The exact prevalence of thyroid disorders in Bangladesh is unknown and believed to be above 20%. It is estimated that 50 million women suffer, 50 million people are suffering, and 30 million even don't know about their own condition. They are not aware about it. Females are 10 times more at risk than the males. 20 to 30% women suffer from some form of the disease. Iodine deficiency disorder more in north part of the country. There are in early 80s, clinical experience and few laboratory tests were the only means for evaluating thyroid disorders in Bangladesh. Modern laboratory tests evolved gradually over the last 25 years, making it available, the thyroid test with high sensitivity and specificity. Both government of Bangladesh and professionals' initiatives have been taken to address the issue. Present situation, iodine deficiency disorders now improving due to initiatives taken by the government and by NGOs and other other partners, but with the more diagnostic facilities, it is shown that the autoimmune disorders are increasing. Nodular goiter is about 50%. Cretinism is high. Thyroid disorders in pregnancy is still high. Awareness with the updated guideline in general is poor. Diagnostic facilities are there, but not widely available. Our treatment facilities are good, but proper treatment sometimes is not available to everyone. Though there is no national data, some studies have estimated that about 3 crore 60 lakhs women in Bangladesh, 60 lakhs people are suffering from thyroid diseases in Bangladesh. And estimated that it is 20 point. From this study, it is estimated that it is 20.43%. The study was conducted in the south part of the country. 7.35% had decreased goiter, and subclinical thyroidism, hypothyroidism was 6.59%. And hypothyroidism, overt hypothyroidism is about 5%, and autoimmune disorder is about 15%. There is a changing trends. The changing trends could be due to the improved in the diagnostic facilities, and also some initiatives taken by the government to address the iodine deficiency, and the government has some programs on addressing the issue. Before 1993, Bangladesh had a high prevalence of iodine deficiency and consequent endemic goiter. Universal iodization of salt, which was introduced in 1993 and lasted up to 2010, changed the scenario. Bangladesh has achieved measurable progress in reducing the iodine deficiency and goiter rates, but the physiological iodine deficiency persists among more than 1/3 of the children and women. If you look at this graph, if you see there from 1993 to 2004-05, here it's shown that there is a decline in the goiter due to the improvement in the iodine supply of iodine and due to the improvement in iodine deficiency. And a study conducted showing to see the median urinary iodine and the prevalence of iodine deficiency in school children in 1993, 99, and 2004-05. And there it has shown that both in boys and girls and overall there is a decrease in the increase in the median urinary iodine, and so there is an improvement in the iodine deficiency state. Summary results of iodine deficiency survey in Bangladesh. One survey was done, which shown that the total goiter from 1993 to 1999 and 2006, it has been improved. The goiter prevalence has been decreasing, and the prevalence of visible goiter and cretinism also decreasing and decreasing. Spectrum of thyroid disorder in a clinic, in thyroid clinic of Bangabandhu Sheikh Mujib Medical University has shown that in 1995, the percentage of simple goiter, multinodular goiter, non-toxic goiter, hyperthyroidism and hyperthyroidism in 1995 and in 2003. So there is a decrease in the goiter, but there is an increase in hyperthyroidism and also hyperthyroidism. This may be due to the increase in the, not only the increase in the, due to the increase in the diagnostic facilities. Iodine nutrition status under various cutoff value in different age groups of the school children is also has been shown, and in all the age groups there is an increase in the iodine nutritional status, though it is still less than WHO recommendation level. Urinary iodine level in simple diffuse goiter and in control is shown in a study. And it is also has shown that in this study, it is shown that both simple diffuse goiter and in the control group, the urinary iodine level is 100 more than 10%, more than 10 picogram per dial in 100% of the cases. The study conducted in BSMMU and published in Bangladesh Medical Research Council, and the study was done for the overt and subclinical hypothyroid among Bangladeshi pregnant women and its effects on fetal-maternal outcome. It is shown that it was found that significant adverse effects on maternal and fetal outcome were seen, emphasizing the importance of routine antenatal thyroid screening in the country, because though it is not recommended universally, but due to the high prevalence in the country, it is recommended routine screening. The adequate treatment of hypothyroidism during gestation, during pregnancy can minimize the risk and generally makes it possible for the pregnancy to be carried to the term without much complications and with improved neonatal outcome. Iodine nutritional status, a study has tried to evaluate the iodine nutritional status under the various cut-off values in different trimesters of pregnancy. And it has been shown that though WHO recommendation is 50 microgram per liter, but during the period 2093 to 2006, 99 and 6, there is some improvement, but still it didn't reach the WHO recommended reference range. Some more studies was carried out in GSMEMU by the different investigators to find out the status of the subclinical thyroid, subclinical hypothyroidism, overt hypothyroidism, euthyroid, and subclinical hyperthyroid and hyperthyroidism. That means the thyroid status of the women during pregnancy. And it is shown that the subclinical thyroid hypothyroid is more than the overt clinical hypothyroid. In most of the studies, it is shown that. In summary, I like to say awareness about the problem had increased, but diagnostic facility is still not widely available. And awareness have increased, but it is not up to the mark. More awareness building is necessary, and the Endocrine Society and other societies are continued to build the awareness among the population, and different initiatives have been taken to improve the status of awareness among the population. Modern treatment of thyroid disorder in pregnancy and women is still challenging. Treatment facilities drugs are available, but treatment in time can prevent complications in mother and children. But inappropriate treatment of unconfirmed cases still exist, and due to the absence of universal guideline or country level guideline for every thyroid disorder is not yet well available. So it is challenging. Interest in thyroid disorder among physicians are rising, but need more specialists in the field to address the issue. Coordinated team approach could improve the outcomes of thyroid disorder management. Like to recommend conduction of nationwide survey to estimate thyroid disorders, screening of thyroid disorders for the high-risk group, such as women, especially those who are pregnant and planning for pregnancy, is recommended. Universal neonatal screening could improve the neonatal outcome, and all of us know if it is treated in time, we can prevent many complications in the children, especially the development and the intellectual behavior of the children during pregnancy and early neonatal part. Building awareness about the disease and need for intervention focusing on dietary modifications are also important. Institutional participation in screening awareness building is necessary. The government has some initiatives and some programs, but strengthening of the government's holistic approach is needed, and more research work is needed in this field. On behalf of our patients, we like to thank you, Safo, for this wonderful program and to take the initiatives to address this important issue. Thank you so much.
Thank you, Saiba ma'am. Now I'd request Sameena ma'am to conclude the webinar.
I want to congratulate Professor Saiba Akhtar for the wonderful presentation. And she has mentioned about the country situation, about the congenital hypothyroidism. And one good thing is that congenital hypothyroidism screening program is going on since last 20 years in this country. But still it is confined to only in the bigger hospitals. But it is not in all the medical colleges. So I think we need to give emphasis on that issue. And she has also mentioned about the iodine deficiency disorder, and which is very much prevalent in our North Bengal side. And but since 1993, after the introduction of iodized salt, it came down, as we have seen in Nepal presentation. It's also like that, but we need to give more emphasis because we have found that still it is there. And there is also one thing is very, I think we need to think over that 3 crore and 60 lakh population is suffering because it's a very big number. And it shows that we need to identify the cases, and before that we need awareness creation. Awareness creation for both the people and also from the healthcare provider, both are needed. Because if we don't tell the people that what is the sign symptom of this hypo or hyperthyroidism, when they will inform the patient, that is very much important to note that. And diagnostic facilities is very limited, but still I think that our all OB/GYN, they are routinely doing this in their private practice and also in their clinical work, that on booking the patient, they use this diagnosis, at least TSH level. But I will be very happy if we can do it before pregnancy. That will be better. But when we get the patient, if we diagnosis is done during pregnancy, already during that time, 3 or 4 months already passed. So it is better to have it in pre-pregnancy time. And she mentioned a very important issue that we have to do something. We can do with the Endocrinologist Society and OB/GYN Society together, what we can do for our universal screening and also the universal treatment recommendation in our country. And she also mentioned about the subclinical status of the thyroid disorder is more than the overt one. So this is an important issue. So we need to work on that, and I will request SAPOG committee and to have a common recommendation plan for this SAPOG country, so that we can use the almost a standardized protocol for all this content. Thank you, Saiba Akhtar, for excellent presentation. Thank you very much.
Thank you.
For giving me the patient sharing.
Thank you, ma'am. Girja, ma'am, you would like to say something?
Yes, I must thank Dr. Sadhna to give us this opportunity to be here as chairpersons along with stalwarts and especially on the SAFOG committee. And it has widened our vision to identify that we need to come to some uniform understanding. What is very important and relevant in the context of gestosis, I would like to say that we have conducted a study of nearly about 1,800 women in various parts of the society where we found that this is an ICMR project, that every trimester hypothyroidism was significantly associated with hypertensive disorders of pregnancy. So therefore, it's not only a disease which is going to be affecting pregnancy, but it can also affect post-pregnancy issues and the babies. And that was wonderfully brought about by all the speakers who spoke in this typical country perspective. And if you really look at it very deep down, you'll realize that all of us have nearly similar kind of problems. We require to come on the same page, on the same desk, and try to do something which will be uniformly acceptable and implemented. Thank you.
Thank you, ma'am. And this brings us to the end of this first session, the wonderful session. And I would like to thank the chairpersons once again, Malhotra sir, Dr. Sameena and Girja ma'am, and the speakers, Dr. Ashmita, Dr. Richa, and Dr. Saiba. I would now invite my co-coordinator, Dr. Maushami Das, for the further proceedings and to conduct the second session. Over to Dr. Maushami.
Thank you, Dr. Amrita.
Good evening.
Yes, ma'am.
Respected seniors. The second session is on special perspective. We have 4 chairpersons from 4 different countries of SAFOG. Professor Aziz-un Nisha Abbasi from Pakistan. She is FRCOG, MRCOG, FCPS, DGO, MCPS with special interest in urogynecology. We have Professor Kohinoor Begum from Bangladesh. She is the HOD of Dhaka Medical College, Sir Salimullah Medical College, Dhaka, and Mymensingh Medical College, presently working in Popular Medical College as a professor. She has various publications and scientific papers, and she holds various positions as President RHSTEP, Secretary General of Bangladesh Association for Prevention of Septic Abortion, Vice President in Bangladesh Perinatal Society, President of Pediatric and Adolescent Gynecological Society of Bangladesh. We have Dr. Preeti Kumar from India. She is the co-chair of Maternal and Perinatal Committee SAFOG, chairperson of Safe Motherhood Committee FOXY, director of Sunflower Medical Center Lucknow, organizing secretary of AICOG 2020, Lucknow Gestosis 2019, IH 2018, and North Zone Yuva FOXY Conference 2017. Presently, she's the Vice President of Lucknow Obs and Gynae Society. She's a core member of various organizations like Prevention of Violence Against Women, Cell of FOXY. We also have Dr. Padam Raj Pant from Nepal. He is the professor and HOD, Department of Obs and Gynae, Tribhuvan University, Maharajganj Medical Campus. He is the chairman, Department of ONG, Grand International Hospital. So to start the session, may I invite Professor Aziz-un Nisha Abbasi to introduce Dr. Sadhna Gupta Madam, who is our first speaker. The topic is thyroid disorder in pregnancy.
Ma'am has not joined, I guess.
Okay, then may I request Dr. Padam Raj Pant, sir? Sir, please introduce our first speaker, Dr. Sadhna Gupta Madam.
Good evening again. Dr. Sadhna Gupta is co-chair of SAFOG NCD committee, and she is FOXY representative to SAFOG. 2018 to 2021, ICOG Governing Council member from 2015 to 2021, and she is awardee for Best ICOG Governing Council member 2021. And Dr. Sadhana has many other achievements. I will not, she is well known to everyone, of us. So Dr. Sadhana Gupta, please, floor is yours.
Thank you, Dr. Padam, for this introduction, kind, and my greetings to all dignitaries and faculties. And let me share my screen. So my work has been made simple by the previous speakers, and I will touch upon the clinical intricacies of thyroid disorder in pregnancy and leave, I will skip what our previous speakers has done. So as a epoxy representative to SAFOG and SAFOG Association has been really some of the very learning and a very contending experience, and we look forward for the greater and stronger association. So whatever it is, we will just go when the Thomas Walton says that thyroid gland was what it is named, it is a oblong shield, and he presumed that it was to fill the beauty of the neck to the woman. And rightly, the thyroid disorders are much more common in women than men, and because it may be the all endocrine complexity of women, which the woman goes through the pregnancy and the menopause. So it is really great to know that somebody presumed that the thyroid gland was specific for the woman. We need what we have kept this session because the two female population need the routine thyroid screening, that is pregnancy and elderly women. Today, we don't want to see the overt thyroid disease. We don't want to see that big goiter because now we have a good sensitive laboratory tests which are easily available. And as a clinician, the key to early diagnosis is to maintain high level of suspicion. What are the questions ahead in day-to-day clinical practice? One is universal versus selective screening. So we can say South Asia is on the one page. What is the method and timing of screening of thyroid disorders? Issue of gestational age and population specific reference interval, and how we can treat the hypo and hyper and the spatial situations. So thyroid dysfunction has got a great impact on the pregnancy outcome. It is the second most common endocrine disorder in pregnancy after GDM, and we will just see that it has associated with adverse maternal as well as the neonatal outcome. Issue is that we really need to create population and gestational age specific reference values, and as a South Asian leadership, we have much to do in this field. So a quick recap of the thyroid physiology, why it is needed, because there is increased estrogen, which cause increased level of the total T4 and T3 and decrease in T4 and T3, and that makes a clinical implication. And in diagnosis, there is a depletion of iodine, there is a concentration of enzyme deiodinase, and that makes the value which we take in non-pregnant status is different for the thyroid function, what we take it in the pregnancy. Again, to make the thing complicated, there is a structural homology between SCG and TSH. SCG act as a thyrotropic agonist, and it is a mirror image, more SCG and less TSH. Beauty of nature's balance is that despite all physiological change, pregnant woman is euthyroid with normal range of T3, T4 and TSH, who don't have any thyroid disorder. So this is the all physiological change that we know and how it makes the effect on our reading and the interpretation of thyroid function test. Another important thing, when Bangladesh and every country share their perspective that we have to go for our generation next neurodevelopment and the cognitive development, which is so very important for every country. And the fetus thyroid concentrate iodine and start secreting thyroid around 10 to 12 weeks, and it is optimum after 20 weeks of gestation. And before that, fetal brain is dependent on the placental transfer of maternal T4, and it is a two-way flow, but there can be small and significant transfer when maternal level are very high, and that sets the stage that we as a obstetrician and gynecologist and our women need to have the preconceptional or earliest diagnosis of subclinical or overt thyroid disorder, because it is affecting the long-term development of the fetus and the neonate. Now, universal testing, we all agree, but how to do and how often to do. So these are all studies which we are also sharing that it is very common in South Asia. There is a high prevalence of thyroid dysfunction, and there are a lot of obstetrical adverse outcomes. So Western world, here the Western world differs from the South Asian countries, and Western world is not on the same page. They have the different value that they don't recommend universal screening for healthy. But in South Asia, the way we are more prone to have the gestational diabetes mellitus, the way we are also more prone to autoimmune thyroid disorder, as well as the iodine deficiency thyroid disorder. And that sets the stage that the South Asian women need universal screening of thyroid disorder in the pregnancy specifically. So these are all studies which highlight that we need to have the universal screening, not the case-based screening, because it fulfills all the criteria of an ideal screening test. So now the second question is, what are the values? So what our Indian Thyroid Association FOXY 2019 guideline says, it is first trimester upper limit is 2.5, and second and third trimester is the 3 IU per liter. So this is very important, and we have to know the lower limit as well. Now TSH, we are all fine. Now the question is whether we should do the TPO antibody testing. So here is our clinical acumenship, because 10% of pregnant women show increase in TPO antibody titer, and it can be related to subclinical hypothyroidism, adverse obstetrical outcome, as well as the postpartum thyroid dysfunction. So one message which we want to give to all: when we have to do the TPO antibody testing, when there is a personal history of thyroid or other autoimmune disease, family history of thyroid disease, patient with the evident goiter, bad obstetrical history, previous preterm delivery or the pregnancy loss, and women with type 1 diabetes. So these are the patients whom TPO antibody titer should be considered, and it should not be avoided. Another important thing is maternal thyroid dysfunction by itself is not an indication for termination of pregnancy, because many women ask this question if they have got the high TSH level, that what will happen to the baby. So even the later start of the thyroid function disorder improves the outcome. Now coming to, I will be quick in the management of all the things. Hypothyroidism in pregnancy, we think it is very simple. We just have to give the L-thyroxine and it is nothing. But there is always a complexity in simplicity. These are all classical features of overt hypothyroidism: fatigue, constipation, weight gain, cognitive disorder, memory loss, bradycardia, goiter. Still we see sometime in the rural population, in poor population, the frank all symptoms of hypothyroidism, but our aim is to detect the subtle thyroid dysfunction before they become too overt. These are all complications: maternal complication, anemia, it can just give heart failure, mood disorder, all what Dr. Girija says, all the gestational hypertension, that is hypertensive disorder in pregnancy, abruptio, more cesarean, more preterm delivery, more PPH, and more postpartum depression, and the lactation problem. And the generation next health, that the fetal is having IUGR, increased perinatal mortality, recurrent pregnancy loss, and of course neurophysiology, psycho-intellectual development. So it is a quick recap that the TSH should be for all. If TSH is elevated, confirm it with the F3, T4 and TPO antibody titer so that we can detect These patients are having subclinical hypothyroidism, and these patients are more prone to develop the thyroid-related disorder in later life. This is very important because always we want to keep the TSH level below 2.5 in first trimester and below 3 in the second and third trimester. So the dosage schedule, how we should do, it is 25 to 50 at the certain level, and if the serum TSH level is high, then how we can do the dosage regulation for the thing according to TSH level. And that, as a obstetrician gynecologist in South Asia, we must be aware of what is the dose of that L-thyroxine we want to give. It is a 30% increase, what Richa have already done or already shared, and how to monitor. Now, this is also very important because sometimes the patient get monitoring at every month, and sometimes they don't get monitored in pregnancy, only in once or twice. So the second clinical message is that 4 to 6 week interval in first trimester and at least once in second and third trimester. Few authors recommend that FT or FT4 level for monitoring because it is more closely reflecting the hormone which is available to placenta. So subclinical hypothyroidism and euthyroid women with antibody positive. These are few gray areas. What everybody has said that it is a day-to-day clinical problem that this patient should be treated or not treated. So what is the current perspective that subclinical hypothyroidism, when we define, when there is an increased TSH, but normal concentration of free T4. When we say it is subclinical hypothyroidism, they are more likely to have TPO antibody positivity. So in these patients, it is better that before we start treatment, we do the TPO antibody titer. Etiologies are similar, and studies shows that if the subclinical hypothyroidism is treated, especially with autoimmunity, then they result into the good outcome. But it is not being proven to modify long-term neurological development in the offspring. So these are all studies that the subclinical hypothyroidism also cause the adverse obstetrical outcome. And this is the very important table that if there is a 2.5 to 4 and it is TPO antibody positive, if we give L-thyroxine, there is a significant difference in preterm labor. But if it is TSH level is less and the TPO, it is more than 4 and TPO antibody is negative, it is a gray area, and we have to follow these women with the close monitoring for the thyroid dysfunction. So we have to have a little understanding of thyroid antibodies. These are the two antibodies, anti-TPO and TSH receptor antibodies. And the recent studies have demonstrated that a high proportion of adverse pregnancy outcome when there is a anti-thyroid antibodies, and they can have the disturbed thyroid dysfunction. It is important to know that the thyroid receptor antibody can be detected in first trimester, but value often decrease during second and third trimester. So it is important that if we measure antibody pattern, then it is better that we do it in first trimester, because at that time we can have a better interpretation and better follow-up of these patients. So it is all studies which shows that the pregnancy outcome in patient with autoimmune thyroid disorder, especially if the TSH is above 4, it results into the good outcome. These are the ITS and the FOXY recommendation, which I have already covered, that LT4 is recommended always when TSH is greater than 10, and TPO antibody positive when TSH is between 4 and 10 IU. And LT4 therapy should be considered for TPO antibody negative with TSH between 4 and 10, and TPO antibody positive between 2.5 and 4, because it improves the obstetrical outcome. So these are all new recommendations, and we have to be aware of it, that the thyroid autoimmunity is the thing which we have to understand, and these patients require the postpartum observation for the postpartum thyroiditis, as well as the postpartum persistent thyroid dysfunction, because especially women with thyroid autoimmunity need annual monitoring with TSH all over their life. So it is important that we understand the thyroid autoimmunity, when to do, which are the patient, and how to follow them. Prescribe well. So it is important always the thyroxine to be taken empty stomach. Don't prescribe them with iron and calcium. Few drugs increase an LT4 requirement. If the patient is taking anti-tubercular steroid or anti-convulsant, then we have to tighten the dose. And all professional bodies all over the world strongly recommend not to use other thyroid preparation, like we have the desiccated thyroid and other thing in the pregnancy. Iodine requirement, a huge sub-Himalayan belt is there with iodine deficiency. In South Asia, we have to consider that the women get the good iodine uptake that is around 200 to 250. Excess is also not desirable, and where the iodine is depleted, there is a iodine related thyroid disorders are very common. And with iodized side, everybody have emphasized, and the micronutrient are the other way where we can ensure iodine uptake to the patient. So this is the takeaway: universal screening, screen all by TSH, diagnose autoimmune, follow mother and fetus closely. We want an accurate thyroid level that is 2.5 and 3. Over treatment is also detrimental, and subclinical hypothyroidism need close monitoring for all and treatment. So a little bit hyperthyroidism also, it is less common, 0.2 to 0.4%, and there can be the physiological one, that is gestational because of the analogy of HCG and the TSH, and it can be the goiter, Graves' disease, and the other thing. Clinical features. Now, this is important because we have a big OPD, and every patient says nervousness, tachycardia, but it can be the symptomatic or physiological. It can be due to the anemia, but few things are important, that is frequent stall, heat intolerance, insomnia, palpitation, and the distinctive sign of Graves' disease, that is the eye sign. So diagnosis can be difficult if we are not careful. So we have to have a good look on the patient, and we have to think that if there is a resting pulse rate more than 100 minutes, which is not decreased by Valsalva, is strongly suggestive of the hyperthyroidism, and we have to check the lower limit, which is 0.03 in first and second trimester, and in third trimester it is 0.13. If there is a subnormal serum TSH, we have to differentiate between normal gestational thyrotoxicosis and the Graves' disease. It is a specific clinical trial, goiter, thyroid antibody, and the TSH receptor antibodies. Again, complications can be preeclampsia, heart failures, thyroid storm, which can be life-threatening crisis, IUGR, preterm birth, and the stillbirth. So we have to treat it, and the Graves' disease get aggravated in first trimester, and a little suppression in second and third trimester, and again increase into the postpartum. So how we should manage it? Subclinical hyperthyroidism need not to be treated. It is very important because it is not associated with adverse obstacle and neonatal outcome. Always a woman with a hyperemesis gravidarum should be tested and followed for thyrotoxicosis, and the transient biochemical hyperthyroidism, which is at the physiological peak, that is around 10 weeks, should not be treated with antithyroid drug, but they have to be followed after 1 month for thyroid function test. So as a clinician, we should be very, very clear to diagnose physiological one, gestational thyrotoxicosis, and the Graves' disease. Should we treat hyperthyroidism? Yes, because it is associated with the adverse obstacle outcome. So what are the treatment? Usually for hyperthyroidism, we wish to refer to endocrinologist. But in South Asia, common problem is that OB-GYN has to have the basic knowledge and has to have the multitasking. So propylthiouracil, carbimazole, and methimazole are the drug of choice. Usual dose is 100 to 200 milligram PTU and the 10 to 40 milligram methimazole. All are equally effective, but we have to prescribe lowest possible dose of antithyroid drug because all antithyroid drugs are related with the embryopathy and the teratogenicity. So that's why in subclinical hyperthyroidism, a little bit hyperthyroidism need not to be treated, especially in first trimester. And we have to be very, very careful that all antithyroid drugs can cause teratogenicity. The current recommendation is using PPTU in first trimester because methimazole has been found to be more teratogenic In the second trimester, shift propylthiouracil to the again methimazole, because propylthiouracil has been found to be associated with the liver dysfunction. So this is important that as an obstetrician gynecologist, we are in a good rapport with the endocrinologist so that we can save of the minimum teratogenic risk of the anti-thyroid drug, and this knowledge is very, very important. We want to have FT4 in the upper normal range. It is not a very optimal and a very strict control. Initially, we may need beta blocker and then anti-thyroid drug. So these are all guidelines which we have just discussed. It is a sum up what to be treated and how to be treated, and it is important. Now, this slide is again very, very important because in Graves' disease, maternal TSH receptor antibody cross placenta and can cause fetal thyrotoxics and fetal death. That is maybe the unexplained cause of stillbirth. So in the TSH receptor antibodies are positive, then this fetus need to be followed with ultrasound and for the fetal heart rate. If fetal heart rate is more than 160, then we have to think for the cord blood sampling, and then we have to treat the fetus with all the dosage adjustment. If the reduction of dosage of anti-thyroid drug is ineffective in reducing the size of goiter, then the fetal thyrotoxicity should be suspected, because TSH-like antibodies transfer through the placenta and cause fetal hyperthyroidism. So now, in today's time, this is very important that in all TRAB positive patient, we have a close ultrasound and ask our ultrasoundologist to have a look on the fetal tachycardia as well as the fetal goiter size. This is the duty which we owe to our patient and the next generation of the fetus and the newborn. Surgery usually not needed, but there is certain selection of the patient who cannot be treated with anti-thyroid medication. They are non-adherent to ATD, or very high dose is not able to treat the desirable level of control of hyperthyroidism. If surgery is needed, that is always in the second trimester. Radioiodine is contraindicated in the pregnancy treatment. So this is all what we have taken: PTO first trimester, CMI, MMI in the second trimester, and a good watch on the maternal thyroid function, and in the good watch for the fetal tachycardia and the fetal goiter. Thyroid storm is a very rare situation, but it can be life-threatening in hyperthyroidism. The stress factors are labor, cesarean section, infection, anemia also can be there. And the treatment is always multidisciplinary: anti-thyroid drug, cold iodine, beta blocker, steroid, and management of precipitating event. So saving mothers is always our priority, and we have to be well aware with the basic knowledge. All patients with the thyroid dysfunction in pregnancy or before pregnancy need to look for the postpartum thyroiditis. Special risk situation are women with history of autoimmune disease, insulin requiring diabetes mellitus, and previous history of postpartum thyroiditis. So this is important that we have to follow these patients. Initially, there is hyperthyroidism. It is followed by hypothyroidism. Hyperthyroidism does not require treatment, but the women who turn to euthyroid status should undergo again long-term annual lab surveillance for the thyroid status. And out of these, 20% will develop hypothyroidism in next 5 to 10 years. So it is the gestational period is so very important that we have to teach the patient and their family that they have to have the annual surveillance for the thyroid function. Thyroid nodules in pregnancy, never ignore it. The investigation are the same. It is ultrasound scan and the serum TSH. Radionuclide scan is not, it is contraindicated. Molecular testing has not been validated. One message is never ignore thyroid nodule, because thyroid cancer are second cancer after breast cancer in pregnant population. FNAC criteria are the same. But if the nodule is small, less than 2 centimeters, not increasing in size, no lymphadenopathy, we can defer thyroidectomy after pregnancy and place the woman on anti-thyroid drug for the suppression. So this is important. Every thyroid nodule needs same road plan for the thyroid nodule evolution. So to conclude, thyroid gland and hormone play unique orchestrated symphony in human body. Especially South Asian women are more prone to thyroid disorder. Pregnant women are high risk and vulnerable population. Thyroid disorder need universal screening, proper interpretation, and good evidence-based management, and proper management of follow-up of thyroid dysfunction, and the short as well as long-term maternal and neonatal outcome. Thank you for the active listening. Women's hormone symphony is the 8th sense. So the women are considered like a little higher creation of God. Stay tuned for the future program. Thank you once again for being with us on the CEPHOG NCD committee webinar, and we look forward for many, many programs and a very, very strong association. Thank you very much.
Thank you, madam. May I request Padamraj Pant sir to share his experience on this.
Thank you, Dr. Sadhana, for your excellent presentation covering thyroid disorders in pregnancy, starting from physiology of thyroid, screening of thyroid disorders, consequences of thyroid disorders, management, everything was covered, and it was very excellent presentation. Thank you once again.
Thank you, sir. Thank you, Sadhana, madam. Moving on to the next topic, thyroid dysfunction in elderly women. May I request Professor Kohinoor Begum from Bangladesh to introduce our next speaker.
Thank you very much. It's my pleasure to introduce Ambuja Konakur. She is a retired professor and head of the Department of Obstetrics Society of Osmania Medical College, Hyderabad, visiting professor Savita University, Chennai, president Indian Menopause Society, vice president Family Planning Association of India, faculty and research person, National Board, treasurers of Society of Obstetric Medical India, Medicine India, and peer reviewer. So thank you, madam. For now the floor is open for you to present your case. The thyroid disorders in elderly people. Very important topic, at least for us.
Thank you. Thank you for introducing me, and a kind regards to all of you. Where am I? Don't know why it has come. Just give me 1 minute time to go back. Yeah. Respected dignitaries of CEPHOG NCD committee, and all the chairpersons and all the faculty members, good evening to all of you, and especially Sadhana for including me as part of the webinar. Thank you very much for the opportunity given. Today, my talk is Thyroid Dysfunction in Elderly Women, Indian Perspective. I bring greetings from Indian Menopause Society to CEPHOG. Not like the previous people who were giving so much of information, but you know, menopause is not such a widely studied subject. Not many papers are published, not authenticated papers are there, but still whatever is available, we have guidelines, Indian guidelines, what we are following at present. I'm going to present that one. And two things which we have to accept in menopause. Menopause in India is average age is 46.2 years. I hope it is the same for all the CEPHOG countries. That means it is 10 years ahead of the Western countries. Means the women is going to stay in the estrogen deficiency stage for 10 years. That is the reason why they are more prone for the cardiovascular diseases and non-communicable diseases. And another problem in India is the dia-obesity, that is the diabetes and obesity is increasing, which has become a hub for that one. And premature ovarian insufficiency is another problem that is there for us. Maybe it is iatrogenic or because of the epigenetic factors that are there, increasing population and reactive oxygen species, all these things put together, we are more prone for that. With all this in mind, what are the problems which we are going to face and how to manage a postmenopausal women with the thyroid disorders? As you know, these two things are very common, endocrinological. This is the second one. And next to the diabetes, thyroid is there. And global incidence, India here, it comes as the more than 2% of the Indian population or thing. And prevalence in menopause, there is a big study that is being done, 20 years follow-up study in Britain. Age-specific hazard ratio it has given means between 65 to 74 years, 16 per thousand per year, women are added. They are going to develop hyperthyroidism. More than 75 years, 21 per thousand per year added. But hyperthyroidism, you see, it is not so much. Between 18 to 24 years, it's only 2.2 per thousand per year. But after that, until the age of 80 years, irrespective of what is the state of the estrogen present or not, less than 1 per thousand it is present. If you go to the Indian statistics, we have three major statistics that are being done recently. That is one by Dr. Unni Krishna, Kerala, South India, it is there. And another is middle of India, that is the Wardha they have done. And one Priyanka Sharma from Delhi. For all of them, the prevalence is from 7 to 34% in menopause. And hyper is only 1 to 2%. And the postmenopausal age group, and it is increased with age, hypothyroidism again is 10 times more common than the hyperthyroidism. As you see, it is the euthyroid people are more than the hypothyroidism. So one good thing is always think positive. Euthyroid is more than the hyper, so we can control the rest of the things. What we should know about the thyroid and menopause, that's what is more important for us. Does thyroid physiology change with age? Yes, normal physiology already Sadhana has told a lot, but I'm not going to tell. But one thing is very definite, she said, the decreased TSH levels are because of the increased estrogen. But here I already told you that estrogen is decreased, that's why TSH is increased. The gland size, uptake, that is the thyroid size, uptake of iodine is decreased, T3, T4 is decreased. In turn, this is the TSH is increased. And thyroid binding globulin is decreased because this is acting in the liver. This is the estrogen deficiency stage, and estrogen dependent is the thyroid binding globulin. Not only that, the receptors, thyroid receptors that get into the cells, they are dependent on the estrogen is present. All put together, hypothyroidism is more common in the menopause. We are starting the registry in Indian Menopause Society, that is started last year. It's going to be for 10 years. Maybe after that, I'll be able to give you the exact data, what it is. We are struggling hard and invested so many lakhs of rupees for starting that registry. All over India, it is being done. And what is the thing is prevalence of TSH by age and gender. That's what is the thing which is made. Up to 40 years of age, it's almost the same, male and female. But in the female, after the age of 40, it is increasing. Means this is a thing which is when it is increased, more of cardiovascular accidents and more of dementia, they are more common in the menopausal women. Next question comes, does thyroid function test change with age? Yes, definitely it changes with the age. And TSH, this is a large study with 13,000 people that is being done. And where they have done the TPO antibodies also. And this is the National Health study that is there. And definitely there is increase in the TSH as the age goes. Means we should be aware that normal conditions also TSH is more. Don't treat TSH values as it is being done in the reproductive age group. That's what is very, very important to understand. Means in the reproductive age group where estrogen is present, we are going to, normal is 0.4 to 4.5, but in the postmenopausal age, where TSH is going to increase, don't treat the that one, because I'll show you what are the problems. Or vasomotor and menopausal symptoms related to thyroid status. Once upon a time, we are telling age is the only factor that is involved, and thyroid is not much, it is there. But in 2020, it has produced, the climacteric symptoms are related to thyroid status in euthyroid menopausal women. And it showed inverse correlation between sweating, palpitations, and weakness and TSH levels. As the TSH levels fall down, when they're going for the hyperthyroidism, these things are very common. What about the hormone therapy and thyroxine levels? This is very important, because all the time we are shouting that we are not using hormones. We should use the estrogens whenever it is necessary. What is that? It is happening. Hormone replacement therapy in women with hypothyroidism treated with thyroxine causes changes in free thyroxine and TSH, means whatever estrogens we are using for the hormone therapy, this binds with the, it produces more of thyroid binding globulin, and it mixes with the thyroxine that is present. So the TSH levels will increase, means a person who is hypothyroid on MHT needs more of estrogens. That on hormone therapy needs more of thyroid. I think I am clear. And laboratory investigation, if we come, these are all the guidelines from our society. I have not taken from other things, because it is the Indian perspective. It is the universal screening what we are doing, and the TSH is the only one what we are doing. Depending upon that one, we are deciding whether it is a hyper or hypo. And if it is TSH level is high, then only we will see whether it is a symptomatic or not. And T4, if we do, T4, if it is normal, it is a subclinical. And if it is low, it is the hypothyroid we have to treat. I will tell how we are going to start, a little different from the reproductive age period, how we are going to treat this one. In the same way, low hypothyroid is with the, low TSH is the hyperthyroidism, where the subclinical hypothyroidism, T4 is normal, and T4, if it is high, it is the hyperthyroidism. The progression, what is more important here is why we have to do the T4 and find out it is a subclinical hypothyroidism. The progression of subclinical to overt hypothyroidism is about 2.6 per year, and can double in cases of the TPO positive, that is the autoimmune disease, or if the TSH is more than 10 milli-international units per liter. That's what is very important. The overt hyperthyroidism can become the hypo or hyper. Is routine screening necessary in the peri and postmenopause? Yes. But what the other guidelines are saying, according to our guidelines, we say, yes, we have to do it. But you know, ours is a vast country. People who come to us only, we are not doing the universal one. It is only the clinical, when they come to us, we are doing. The American College of Physicians, they say, yes, after the age of 50, we have to do for everybody. American Thyroid Association says, universal screening after 35 years and repeat it once in 5 years. But US Preventive Task Force found that evidence was insufficient to recommend either for or against routine TSH screening in asymptomatic women. More recently, the British Thyroid Association issued guidelines stating that screening for thyroid dysfunction in a healthy adult population is not warranted. But for Indian circumstances where thyroid disease is more, especially in the menopause, yes, it is recommended until that registry results come down. These are the desired levels. And is hypothyroidism different in menopausal and postmenopausal women? Yes, it is there. Apart from all the other things everybody has described, what we should understand is Unusual clinical presentations can be present. What they are: congestive heart failure, pericardial effusion, neuropathy, macrocytic anemia, cerebellar dysfunction, cognitive decline, major depressive psychosis. All these things we'll take it into granted in the postmenopausal women, and we don't investigate and treat. I have seen people they suffer with severe hypothyroidism with all these things. They will take it as a menopause, and when we investigated, it is a case of hypothyroidism. So there is a common symptoms between the depression and hypothyroidism. That is, a lot of it is present. So how are we going to treat? That's very important. You should not over-treat or you should not under-treat. But not like other pregnancy where you will immediately give 50 micrograms or 100 micrograms. Please don't give it in the postmenopausal women, because initial levothyroxine dose should be 1.6 micrograms per kg per day. Actually, most of the postmenopausal women, especially in Indian circumstances, not everybody is obese, and especially in the rural areas, they are very thin. Don't start a higher dose for them, and wait for 6 to 8 weeks and repeat the thing. And if the TSH is more than 4 micrograms international units, then increase the dose. If it is less, decrease the dose. And if the TSH level is 0.5 to 2 micro international units per ml, so you have to continue the treatment. Measure TSH at 6 months, then annually, and or when the patient is symptomatic. I think I made it very clear how to start and when to see the patient. That's the universal screening. Start with a lower dose and repeat TSH at 6 to 8 weeks interval. And what is the cutoff level for thing and how to manage this one. Subclinical is also very important. You know how to detect subclinical already I told. But only thing is, how are we going to manage subclinical? This is very, very important. It's a matter of controversy how to treat. Age between below 70 and above 70, we have to take. If the serum TSH is less than 10, means between 4 to 10, if the age is below 70, and you see whether the hypothyroid symptoms are present or not. If it is present, you treat. If it is not present, you don't give any hypothyroid drugs. You observe the patient every 6 months, you repeat the TSH level. Understand? And if it is more than 10, definitely you can treat. This is the age group below 70 years. Suppose if it is age group above 70 years, even if it is 10 international units per ml, don't treat the patient if it is asymptomatic. This is very, very important. As the age grows, the TSH level is increased. So don't try to over-treat the patient. That's what is very, very important. Therapy may be considered when TSH is more than 10. Symptoms of hypothyroidism or cardiovascular risk exist. If it is below 10 micro international units per ml, no symptoms, observe the patient and do the 6 monthly repeat thyroid. I think I made it very clear this one. So thyroxine replacement should be very slow, as I already told you. Don't start a thin patient 25 or 50 like a placebo treatment. Don't give and don't imagine and give it up. Start slow, go slow. Very old and very sick and very hypothyroid and cardiac, so it should be very slow. The usual replacement is 1.6 micrograms per kg per day, taken once daily, preferably first thing in the morning in a fasted state. Avoid medications like calcium, iron, and fiber laxatives and thyroxine, because they all interfere with the absorption of the thyroid. So iron, at least you give 3 hours before the thyroid and the iron, and calcium you 2 hours, and especially antacids, minimum 1 hour gap should be given. And the latest is thyroid can be taken in the night, because sometimes in the morning to give such a gap is not possible. So after your dinner, give 3 hours gap and then take the thyroid, because whole night you are starving, you will not take anything. So that's also is on the way, and it has not come into the textbooks, but it is the research work is going on. Maintain TSH levels in the normal range. Yearly testing will suffice to check adequacy and compliance. Test sooner if weight changes and new medications or diet is present. This example, I'll give you one thing. The patient came to me 48 years. She was since last 25 years during pregnancy. Somebody has started her on mild dose of thyroid, 25 micrograms, continued to take without consultation, and menopause 3 years. She came with a hip fracture for minor injury. DEXA showed osteoporosis. When we did TSH, it was very low level. Her question was, I take a regular calcium, vitamin D, protein, so many things. I don't have high risk factors. Why did I get further trivial injury? Under this thyroxine, what we should remember is under replacement may worsen cognitive decline, weight gain, and over placement may cause bone loss, cardiac arrhythmias, hair loss, worsening of glucose control, sleep disturbances, and anxiety. Especially if the patient is obese and diabetic, the insulin resistance will be more, so thyroid dose should be more. But if it is a non-obese diabetic, it can be a normal. One must be aware that over-treatment with L-thyroxine leading to suppressed TSH is associated with increased risk of atrial fibrillation, coronary heart disease events, and significant bone loss, osteoporosis leading to the fractures. These some of the things which we should remember, which interferes with the absorption, like celiac disease, malabsorption syndrome, and liver disease. And old age people, the multipharmacy is very common. Either they will be diabetic, thyroid, or antacids continuously they will be taking. And for them, proton pump inhibitors are antacids when they are taking. It interferes with the gastrointestinal absorption. And especially when they are taking the MHT, I told you, either oral contraceptives or SERMs and the Lux, their TSH will be increased and thyroid dose should be increased. And medications necessary to lower the dose of thyroidine is anticonvulsant medications and rifampicin, anti-TB, and may increase the hepatic metabolism of the thyroid. Hyperthyroidism, a word about it. One must be aware of the fact that in the older population, the higher incidence of drug-induced hyperthyroidism is more common. Post-amiodarone, that is the antiarrhythmic agent, because many people are the antihypertensives and antiarrhythmic drugs will be there. And to treat ventricular arrhythmias or atrial fibrillation, they are on. For them, if you give the thyroid, the dose may be more. Iodine containing contrast media when they are using also, and excessive amount of L-thyroxine. These are all the things will cause the hyperthyroidism. I'm not going into the hyperthyroidism because Sadhana has mentioned everything about it. Right? And treatment also, she finished only one thing. Yes, beta blocker. Why it is? Excuse me, little. Yeah. Beta blockers are not contraindications. We should give the beta blockers whenever it is necessary. So finally, to conclude, thyroid disorders are more common in women and with advanced age. Symptoms and signs may be subtle or ignored as part of aging. Needs a high index of suspicion. Subclinical hypothyroidism is very common and needs careful assessment. Thyroid hormone over-replacement may be associated with bone loss and fractures. Menopausal symptoms and body composition changes may add challenges to the diagnosis. Thank you very much. Thank you, Sadhana, for giving me the opportunity. And very nice program. You have done a wonderful thing in organizing and inviting so many people. Thank you very much. And especially Arla Kumaran sir, to see you after a long time. Really happy. Thank you very much.
Thank you, Madam Ambuja. May I request Professor Kohinoor Begum to share her views on this?
Very, very nice presentation and elaborate presentation on elderly. Many times these thyroid disorders in elderly is neglected, not diagnosed properly. So it is very important in case of all the things about this menopausal. She told only the female menopause, but male also affected by this thyroid hormone deficiency or over. So large epidemiological study have shown that increased prevalence of thyroid function in elderly people. Among these, subclinical and mild thyroid is more than overt thyroid. Diagnosis of thyroid function is difficult in elderly patient because the symptom clinical presentation is not always correlates. So something is difficult to diagnose. Overt hyperthyroid is associated significant risk with cardiovascular disease, osteoporosis, and mortality, especially in the elderly population. So treatment of subclinical hypothyroidism is warranted when serum TSH concentration are undetectable owing to important association with cardiovascular disease and reduced BMD. Biological endpoint of hyperthyroidism correlates with serum free T4 level. The risk of fibrillation, fracture, susceptibility are increased with serum free T4 concentration at the upper third of the upper limit of the reference value. The studies on the long-term consequence of hypothyroidism on the cardiovascular risk are inconsistent, but treatment of serum TSH concentration more than 10 milli-international unit with levothyroxine monotherapy is recommended in most cases. So, if we start the treatment earlier, then I think it will be better for better outcome. Though we must give emphasis on these postmenopausal patients and also the elderly men also. Thank you very much.
Thank you, madam. Thank you very much. Thank you, sir.
Thank you, madam, Ambuja madam, and Kohinoor Begum madam. Moving to the next session, the topic is screening for congenital hypothyroidism. May I request our chairperson, Dr. Preeti Kumar, to introduce our speaker, Dr. Piyali Bhattacharya.
Thank you, Dr. Maushami. It's indeed a privilege and honor to be here. And I really want to thank Dr. Sadhna ji and the committee NCD of CEFOG for inviting me here. And very, very high regards for Professor Arul sir. And he's a great inspiration for all of us. And I really admire that right from the beginning, he's there till the end of the webinar. So thank you so much, sir. And just one more comment before I start the introduction. Dr. C. Ambuja, I attended one of the endocrinology conference here in Lucknow. They have started recommending that we can give the thyroid replacement after 3 hours of meal. And they very clearly presented in their this thing before. What we normally prescribe is empty stomach in the morning. They said that you can give 3 hours after the dinner. So they are prescribing and they are recommending. And this was a Indian Thyroid Society which recommended, and we attended the webinar recently, just 1 week back. So yeah, now can you just, TV of Dr. Piyali, ma'am?
Yeah, that's what I said. All the time we were thinking that we should take only in the morning. It is not like that. We can go for the thyroid take in the night. But only thing is, you just give 2 hours after taking the dinner and you can take the consume, and better absorption will be there because we don't take anything after coffee or anything like that. So better absorption is there.
Yes, ma'am. My net is little unstable, so I have switched off my video. But it's an honor to introduce Dr. Piyali Bhattacharya. She's from my own city, Lucknow. She's consultant pediatrician, SGPGI MS Lucknow. And before I give her academic introduction, I must tell that she's the most humble person that I have ever met in my life. Very helpful, very cooperative, and a great teacher. So she's President Academy of Pediatrics, UP 2019, Executive Board Member CIAP 2017 and 18. She had been recipient of several awards. She had been Zonal Coordinator IAP ALS, Central Zone 2019 and 2020. Member IEFI Committee, State of UP 2017 and 19, 2021, 22. Awarded several times by state chapters and also the national awardee. And I must tell you, she is a great teacher for NRI NRP program, National Resuscitation Program, and she had been a trainer all throughout the country. So thank you so much, Dr. Pyali, for joining today. And we are eager to listen to the screening of congenital hypothyroidism.
Thank you for those kind words, dear. So let me start the So today's topic is screening for hypothyroidism in South Asian countries. So when we talk about South Asian, we all know we have friends here from Afghanistan and Nepal, Pakistan, and everywhere. So the first thing that I would like to bring into everybody's view is the clinical features. You know, the head is slightly larger, there's a large fontanelle, there is macroglossia, there's a distended abdomen, there's sort of hoarse cry, and this is the general typical look. But in the first week, you may not find this kind of a typical presentation. So what exactly happens if undiagnosed? Richa has already told us what happens if undiagnosed. It actually affects a lot of linear growth, a lot of IQ. There may be attention deficits, speech disorders, there may be sensorineural deafness, and of course, fine motor incoordination. The diagnosis is made through serum T4, T3 and TSH values. And of course, it may be supplemented with radiographic studies, with imaging studies, and with thyroid antibody study. Now, secondary or tertiary hypothyroidism, the TSH levels are not high. They are low or undetectable with subnormal levels of T3, T4. So when we say radiological evidence, remember that there will be epiphyseal dysgenesis, there will be shortening of the long bones, and of course, in the head part of the newborn, you will find that there is a lot of cranial deficit. That is, the sutures are wide and the fontanelle is very, very large. So what is the need of screening? Basically, let us come to screening. Screening is ideal when at 3 to 4 days of age. Is there a need of universal screening? We will gradually unfold as we talk of the perspectives in the different countries of South Asia. So many cases are sporadic. Intellectual impairment can be prevented. So if initiated early, that is the catch, that if initiated early. So in the absence of universal screening, newborns with following indications may be screened. Everybody has said that universal screening, yes, not possible maybe, but at least these indications, the first indication, having a clinical feature of congenital hypothyroidism or family history, or a history of thyroid disease or anti-thyroid medication intake in the mother, or presence of other associated conditions like Down's, trisomy, neural tube defects, etc. If these are there, because they are highly associated with congenital hypothyroidism. So when is screening done? So screening, you need to measure T4 and TSH. There are several methods of doing it. TSH, first TSH, then T4, then first T4, then TSH. We will come to that as well. You can measure T4 and TSH at greater than 48 hours of life. The problem occurs when the children are discharged within the first 24 hours. It is difficult. Then you will get a false negative or a false positive report. And the preterms, actually, we were talking about the low birth weight and preterms, they have a higher false positive. So if it is positive at 48 hours, then confirm through a thyroid uptake scan or a USG. And you can also do the maternal autoimmune thyroid diseases measuring thyroid binding inhibitors, IgG. Now, if iodine exposure or deficiency is there, then you measure urinary iodine. Now, screening approaches, as I said, it is done through the cord blood. So, the cord blood, a heel prick is done. And remember, the heel prick is done at the side of the heel, not on the central area. The blood is taken into a spot filter paper, the Puthri paper, And then there are three approaches, as I said. You can look for a primary TSH and back it up with T4, or you can do a primary T4 and back it up with TSH, or you can do both as well. So when do we do the blood collection? Remember, as I said, on the second or the third day of life, 48 hours or so, you do a puncture at the side of the heel. Remember, it is very important to collect this blood. So this blood drop must be right in the center of the circle and it should fill up the circle. So incomplete circle filling again will not harvest the right result. So the first case, as I said, the approach, as I said, was primary TSH. TSH is measured first. Now, if TSH is greater than 20 mu per liter, then we do a T4 to confirm. However, if a T4 is done, then a TSH is done if it is less than 6.5 μg per deciliter. So this is likely, if you do a T4 first, it is likely to miss the milder and the subclinical cases of congenital hypothyroidism, in which T4 may initially be normal also. So the third approach, concomitant to both of these, the abnormal values may be confirmed by a venous sample, but this will incur a lot of costs. We are already thinking about costs when we do these tests. These are a few age-based references which will help you to see whether it is in the normal range or not. Now, if their screening is positive, then if it is normal, you let it go. But if there are clinical features, you need to follow. However, if it is abnormal, as I said, you go for a scan. Now, monitoring is also important, as one of the speakers have told before me. If they have to be monitored, they first 6 months every month, then till 2 years, 2 to 3 months, then beyond 2 years, every 6 months. So if you change the dose of Thyroxine, then you go ahead and you do it takes less than a week for T4 to raise and 4 to 5 weeks for TSH to normalize. And everybody has mentioned that over treatment must not be done. Then you can develop a craniosynostosis or even sometimes a temperament problem. From Indian pool data till 2021, I have come up with this slide which says that incidence pan-India is around 1:887. And that I would say is quite high. So when we did a survey in Bangalore, India showed that the percentages, please note that 79% of obstetricians, 62% of pediatricians, and 95% of nursing staff, and of course 99% of the general public were not at all aware of newborn screening. So there were challenges. There were challenges of illiteracy, there were challenges of ignorance, myths, taboos, superstitions, and of course misbeliefs. And a lack of awareness and interest among our medical and paramedical staff was actually the inhibiting factor. So despite all these obstacles, India actually managed to implement the newborn screening program in 3 states, that is Kerala, Goa, and Chandigarh. Chandigarh caters to 4 urban government hospitals screening 15,000 births a year. Then, of course, we have Goa, which screens around 4,000 births per year. And then we have Kerala, which does the maximum, that is around 1.4 lakh births in a year in over 90 government hospitals. So we are doing this in 3 states and then expanding it. Of course, my hospital has started doing it now, but none of these programs screen births in the private hospitals. However, since in India, maximum deliveries are institutional, we can cover a lot of these by the newborn screening program. Now, one beautiful study was done in this year, I reported. It is on the cost benefits actually. So when they did this, it illustrates that screening is more beneficial than thinking about costs and treatment. The probable intellectual disability in 27,740 children yearly could be prevented in India if a universal newborn screening program comes into scene. So we strongly recommend and urge administrators in local and national health authorities to take necessary steps to implement a viable national level newborn screening program. Now talking about one of my co-countries, Sri Lanka. So I found few studies in Sri Lanka. In latest studies, I have picked them up. So again, they have done a cost-effective analysis. You know, in Sri Lanka, DGHS, as way back in 2010, had issued a circular saying that it should be screened. And they actually did a regional centers everywhere, and then they increased it to other districts also. So in 2019, around 1,59,000 were screened. The coverage was almost 92%. And of these, 192 children were picked up, and of these 126 were even confirmed. So the annual incidence came at 1:1266. That is more than 1,000 live births amongst the screened population. So considering this high incidence of congenital hypothyroidism in Sri Lanka, say 1 in 1,200 births or so, the screening had a huge impact in improving the health and welfare of the society. So again, potentially, economical part is actually becoming more cost effective in preventing so many problems of morbidity. Now coming to Pakistan, I couldn't pick up many studies from Pakistan, but of course, Pakistan, yes, there have been some pooled data there too. A study has shown the incidence as 1 in 1,000 newborns, which is almost 4 times higher than in the West. And newborn screening programs, once established, should give an opportunity if we get the infrastructure to improve the health status in Pakistan as well. This is more of a study that I picked up with the objectives to screen congenital hypothyroidism in Lahore. And over there, they screened people for TSH, and the incidence came to be 1 in 257. So female to male ratio of hypothyroid neonates, as Richa had already pointed out, was more. So it is notably higher in the pediatric community as reported, and the result emphasizes the necessity for a nationwide program. Now, this is a pooled data between 89 to 2018. All these studies in Pakistan I have picked up, and in summary, they show that expanded newborn screening for all treatable and untreatable IEM is carried out at a very few centers in Pakistan, and NBS is a common treatable condition, mainly congenital hypothyroidism, and it is only carried out in Islamabad, Karachi, Faisalabad, in big institutions. So again, we are not having a universal program. Then one single study which was done in the district Dera Ghazi Khan, Punjab, Pakistan, they found an unusually high frequency of, this was a case control study, and they found a very high frequency of congenital hypothyroidism. Again, people have picked up that they are endemic areas. There are areas of iodine deficiencies. Maybe that could explain this. Now about Bangladesh. Bangladesh screening experience. The country was initially 2003. They started preparing for an NBS newborn screening program. Then it was implemented in 1999. But it was only limited to less than 5% individuals. So the national project did not take off. Then in 2019, they came up with a study in Matlab, which screened 1,661 neonates, and 61 samples were found positive. So that's quite a number. You know, when you say that 61 positive, it is now to see what actually happened to these children. So congenital hypothyroidism amongst all the IEMs was the most prominent. 17 of them positive for heel prick and 12 positive for cord blood. So this was quite a high number, which was also found in Bangladesh. When we talk about Bangladesh, remember, it is also in the East Asian countries Pakistan is also amongst the East Asian countries. And therefore, when we talk about these two, remember that, can you see my slides?
Yes.
Yes, madam, it's visible.
Yes,
We
ma'am.
can see.
Yes,
So when
ma'am.
we talk about Bangladesh and we talk about Pakistan, these East Asian companies, the incidence is quite high. In fact, some people have reported 1:600 also. And then when compared to Europe and USA, the prevalence of this thing is, the congenital hypothyroidism is higher in the iodine deficient areas. So talking about Afghanistan, I hope my friend from Afghanistan can help me. I picked up a few studies, but there's a dearth of medical literature on congenital hypothyroidism in Afghanistan. And this is a combined study. In fact, there was only one study which I could pick up, and that was on adults as well. So in this, they have not completed the study also. And epidemiologically also, the reporting is not much. So I hope my friends from Afghanistan do help me out in this. Talking about Nepal. Nepal in 2019, these people did in Kathmandu, most children were detected between the ages of 6 and 36 months, that late actually. There was lack of, again, sufficient data on the prevalence, and current practices of thyroid dysfunction in neonates should be restricted to maternal thyroid issues. This was the recommendation. Then in some selected places, we did the Nepalese pilot studies were done, and again they showed 2 cases of hypothyroidism, 1 case of cystic fibrosis, etc. About the congenital hypothyroidism infants undergoing thyroid function in a tertiary center, they found quite a lot of incidents over there. They actually pooled data, the biochemistry lab data, from 14th April 2013 to 13th April 2020. So 7 years of experience. And amongst those children who had been subjected to thyroid studies, there were around 4.5% who were detected to be hypothyroid. And that was again higher than similar settings in the rest of the country. So then, talking about this, we find that there are barriers to screening program. Number one, there is educational deficit, awareness deficit, even amongst our health practitioners. There are financial, the funding is not there. In India, it is being done through NHM, through RBSK programs. So the funding is not there, and it is quite expensive. In some countries, it is being transmitted to other foreign countries. The Guthrie's paper is being transmitted to other countries for testing. So financial problems. Then the logistics, the delivery, the follow-up, the treatment services. And of course, we need a political commitment for a national newborn screening program to be oriented. Then, of course, cultural problems are there, and there's a lot of sensitivity to such kind of a thing. When you ask the mother to give the newborn's blood, she may not be able to actually allow you to take blood of such a small child. Now, again, there's an update on congenital hypothyroidism 2020, which has given us specific guidelines to for the detection, diagnosis, follow-up of such children of congenital hypothyroidism. Concluding my talk, I would say the introduction of the routine system was started in many countries in the 17th, but from these data show that twice number of CH was picked when compared with countries where screening was not done. In UK, USA, around 25 babies are born with congenital hypothyroidism in 1 lakh births, which is equivalent to 1 in 4,000. But in Asia, this ratio is half. It becomes 1 in 2,000. And in iodine deficient areas like Nepal, sub-Himalayan belt, it becomes further low, and then it becomes 1:1,500 births, and that's quite a high number. UK, USA problem is less common, but it is seen in whom? It is seen in those of African, Afro-American mothers. No. Where is it seen? In infants of mothers of Indian, Pakistani, and Bangladeshi origin. The Indian studies have reported 2.1 per 1,000 incidents. It is much higher than 1 in 1,700 from other regions of India. Similarly, I would request all of you to go through your statistics and pick up belts where newborn screening is really, really needed. Thank you for giving me this opportunity. Thank you, Sadhana ji, and thank you, Safag, for giving me this opportunity.
Thank you, Madam, Dr. Piyali Bhattacharya. May I request Dr. Preeti Kumar to share her experience?
Dr. Maushami, I don't have much experience. I think Dr. Piyali has searched so much, such an exhaustive search on the topic. I must congratulate you, Dr. Piyali. It was such an eye-opener for all of us. And what I still think that OBGYNs, I think, are the first ones who come in contact with the newborns. So they should be basically, the awareness should be among the OBGYNs, what I still feel is not there. So you have given me an insight, a vision, as a Safe Motherhood Committee chairperson of FOXI in India and co-chairperson of Maternal and Perinatal Committee, SEFOG. Now I take it as a mission. I was just going through how best I can implement these in SEFOG and even in FOXI. So thank you so much. That newborn screening is definitely very much needed, and the incidence is really high in congenital hypothyroidism. So thank you once again. We have already exceeded time, so I'll not speak much. We have Dr. Professor Arul sir to give his final words. So I conclude here this session, and thank you so much, Dr. Maushami, and thank you, Dr. Piyali, once again.
Thank you. May I request Dr. Padamraj Pansar to conclude this second session on special perspective of pregnancy, elderly women, and congenital hypothyroidism. Sir, please.
Thank you, everyone, for your excellent presentation. All aspects of thyroid dysfunctions during pregnancy, menopausal age, neonate is well covered. I think everybody should have benefited with these topics. Thank you all our eminent speakers. Thank you very much.
Thank you, sir. We appreciate the presence of Dr. Arul Kumaran and Dr. Farhana Diwan in this webinar. They are still present and attending this webinar and listening to all the speakers. So
sir is also present, Maushami.
Yes.
Professor Rohana sir is also there.
Yeah. I request Dr. Farhana to express his views, followed by Dr. Arul Kumaran.
And Dr. Rohana.
And Dr. Rohana, yeah.
Yes. Thank you so much. Actually, I really enjoyed the webinar. Thank you, Professor Sadhana. Thank you, Professor Sadhana, Dr. Sadhana Gupta, and the organizers for having me. Of course, thanks to Dr. Rohana. He always encourages me, and that is where I get the inspiration. And today I learned a lot. It's amazing how the countries, although their presentations are different, the experiences are different, but at the end of the day, everybody was coming to a consensus that we need to have the levels right and go for what will be the levels and what will be the dose to be given. So that is what I learned from here. And also Dr. Sadhana gave a very comprehensive presentation on thyroid in pregnancy, and it was really very informative. And last but not the least, Dr. Abuja, she presented on the elderly, and that is where we know that we should be cautious in managing the cases. Before ending, I would like to thank Professor Arul Kumar and Professor Dr. Rohana for being with us for all this time. Thank you so much.
Yes, Dr. Arul, please. We are waiting.
Thank you. No, it was an excellent seminar, Sadhana, and I think I should thank both the chairpersons of the committee for organizing this seminar. I learned a lot. Of course, it was too much for my poor brain to absorb everything, but I learned as much as I could. I think it is very interesting about the pediatric neonatal information by Professor Piyali, because I think that is taken up by many countries at birth. So that is something, and I think rightly so, because otherwise they get mental retardation and other problems. So unfortunately for the reproductive age group women, we pick it up sometimes only if they have some miscarriage or some hyperemesis if it is thyrotoxicosis and so on. So sometimes we have to wait for the symptoms. And for the elderly, it looks that we are the poor people who are neglected because we have no idea where to go because there is no universal screening. So I'm just wondering that after a lunch or something, when I'm listening to a webinar, I feel a bit tired whether I'm hypothyroid. Of course, I'm hypothyroid on thyroxine, but whether we should really introduce some wise way of trying to capture the elderly people. So Professor Ambuja's talk was excellent. And unfortunately, we don't do universal screening. So whether there should be some way of trying to help those so that they don't get depression and dementia and so on, because it must have some role. So I think we have to really work hard on that area as well, elderly people, not only women, but men as well. So I think I'm saying for both. So I think there's a lot we are learned, but a lot we have to learn to help the generations, because more and more people are getting older. So we have to focus on that group as well. Thank you very much for the excellent seminar. I enjoyed it very much.
Thank you, sir. Thank you.
Dr. Rohana, we would like to have the last comment from you as a
actually, I don't have anything much to add, but just to say that it was an excellent webinar, and all the speakers and the chairpersons and all the others came out with so many facts and figures and highlighted the problem in this region. And so that it is a problem which we are facing in the South Asian region, and the difficulties we are having in screening and diagnosing, and and the treatment, various treatment methods which are there. So then there are certain uncertainties which have been highlighted, and so it was a good learning experience to all of us, and it gave us an opportunity to understand this as a problem in the region, and what the challenges we are having and what we need to do to overcome and address this issue of thyroid disorders in the region. So I think the NCD committee can take on these things which you were discussing, and also make a fact sheet and make a report, and so that we can go further, and so that this webinar will be quite helpful in planning some further activities and recommendations to this Suffolk region, so that all the others also will benefit from it. So thank you very much, Sadhana and Dr. Dev Padam Raj, for organizing, and also for others. And I thank once again Professor Arul Kumar for staying over the whole program, and for the wonderful comments and given to us at the end of this. So thank you once again to everyone.
Thank you. It is really inspiring that Dr. Arul was there with us. Dr. Fardausi Begum is also with us, and we will, if she is if she has one comment from her, it will be very nice. Professor Fardausi Begum. So I think I saw her comment. So Maushmi, what Dr. Arul says, the male, like the family, it is so. In my experience, in infertile patient, we always screen for women. For all subfertile, the thyroid dysfunction is very common in male as well. So there can be something inheritance from mother to thyroid dysfunction in family, and then the male part is also very important. Though we don't care, but we care for the family. So this is very, very important point for Dr. Sir Arul Kumaran has pointed to us. So thank you once again, Dr. Rohana, Dr. Arul, Dr. Alpesh, Dr. Narendra, all the Dr. Farhana, all Foxy office bearers for this association and making this wonderful evening with a very, very learning experience, and all the leaders from Foxy, Dr. Girija, and all the speaker, Dr. Ambuja, everybody, Dr. Preeti, a very, very dear friend, always with us. And Piali, you have taken really to a different perspective. And as OB-GYN, we look the pediatric perspective, we learn a lot because we hand over the baby to family, and it is always good to know what is happening in the pediatrician and to that child. So we owe a real gratitude to all the dignitaries for all the cooperation, for all the excellent participation, and for their precious time. So over to Maushmi.
Dr. Sadhana, can I just add one thing? I called Dr. Firdausi. Actually, she was fasting, so she's just just given her regards. Yeah.
Can I, with the permission of the chair, can I talk for a minute?
Yes.
A very good evening to all of you. This is a wonderful program. I think the problem of thyroid is such a kind of problem that in our load of other drugs, it becomes submerged, but it is really, really important. And what why I wanted to talk is that in Southeast Asia, the basic screening test in pregnancy does not include TSH. So I think if you go through the WHO documents and our local documents, we do it on our practice, but as such, general recommendation for the country, it's not there. But given that the hypothyroid rate of thyroid disorder is around 7 to 8%, sometimes it's 10% even. So I think we should recommend in the Suffolk region to include TSH in the screening test as far as possible. Thank you so much. Thank you for giving me this opportunity.
Thank you, Dr. Firdausi. So
yes,
let us, Maushmi, you can.
On behalf of Suffolk, please convey our gratitude, Professor Arul Kumaran sir, Professor Firdausi Begum, Dr. Ruhana, Professor Farhana Diwan, Dr. Anish Gandhi, all the chairpersons and speakers. We have a question answer session. So over to Dr. Amrita for it.
Dr. Maushmi, I can see just one question, and it is for Dr. Sadhana ma'am. That is, if in pregnancy, which test is recommended, FT4 or total T4 resting?
In pregnancy, for universal screening, as far as the all logistic, it is only TSH. But if the TSH is above 4, then we have to do the thyroid antibody and the free T4. So total T4, what he said, because of the increased estrogen, there is an increase in thyroid binding globulin, and there is an increase for T4 and decrease in free T4, T3. So if we are going ahead of the TSH is a basic screening test, then we should add the free T4, that is thing, and the practical combination is the TSH free T4 and the TPO antibody titer, which gives you the clear diagnosis of the subclinical hypothyroidism, autoimmunity, as well as the level of thyroid dysfunction for the adjustment of L-thyroxine dose. I hope I have answered.
Yes, ma'am. Thank you, ma'am. And the rest of the chat box is full of the compliments and appreciations. It is full, and especially the newborn screening part is much appreciated. I congratulate you, Piali ma'am. And I can see good wishes and appreciations for Dr. Ambuja ma'am, Sadhana ma'am, Dr. Saiba, Dr. Ashmita, and Dr. Richa Sharma. So thank you all so much for being here. Over to Maushmi.
Excellent moderation.
Thank you, ma'am. Thank you, ma'am. Thank you so much.
Sadhana ma'am, shall we go ahead with the vote of thanks?
Yes.
I think vote of thanks has been, yes, be brief and yes, please. So we can have a good evening. Your voice is not.
You are muted.
Yeah, am I audible now?
Yeah.
Yeah. It is my privilege and honor to deliver the vote of thanks after such an informative webinar. I thank the Suffolk team and the entire organizing committee for this topic And special thanks to Dr. Sadhana Gupta, Dr. Padamraj Pant, Dr. Rohana, Professor Arul Kumaran, who have stayed with us. I thank the chairpersons and the speakers of both the sessions for sharing their knowledge and enlightening us. Every talk was excellent and every talk was like, it had some carry home message. I thank all the delegates from the South Asian countries who have attended the session today. Last but not the least, Shield Pharma for their support. Special thanks to Tulika Tripathi and Sahiti. And to my Master of Ceremony, Dr. Amrita Jaipuria.
Okay, thank you.
Thank you so much.
And, yes, I owe a big thank to Amrita and Maushmi for all the coordination and all the compilation. So we can say good night to all.
Thank you. Thank you,
everybody. Good night. Thank you.
The topic was very good, but due to time constraint, it was too hurry. It was too hurry.
Sadhana, you could have done two webinars, one in the only pregnancy and one in the other.
One in pregnancy and one in others.
Other ages, that would be good.
Maybe
pregnancy